MR Quantification and Artificial Intelligence. What you need to know when reading dementia and multiple sclerosis cases. Why use quantification in MR assessment of dementia? Quantification offers an accurate, reliable, and fast assessment of regional volumes compared to visual interpretation. Imaging is often performed in memory loss evaluation to exclude treatable structural causes. Why not add a volumetric study? Regional patterns of atrophy correlate with different neurodegenerative diseases. There is a time cost to volumetric scans. An MP range sequence at a 1 millimeter volume can take between 4 and 5 minutes depending on your scanner and what other advanced software features you have, such as ACE or compressed sensing algorithms. Another option is to use 3D FLAIR techniques for your white matter burden versus axial 2D techniques, which would be faster but do not offer as accurate information on lesion number. MR interpretation and memory loss. First, you would like to note limits to techniques such as diagnostic quality issues such as motion, slice thickness, are there metal artifacts? When interpreting the images, you want to exclude alternative etiologies such as a subdural hematoma or a tumor or perhaps post-traumatic encephalomalacia. Next, you want to assess white matter disease, particularly white matter T2 burden. This should include assessment of cortical and lacunar infarcts, looking for microhemosiderin on either gradient echo or susceptibility weighted imaging, and then doing a visual or semi-quantitative interpretation of white matter disease. I recommend using the Physicus score, which assesses the deep white matter. Physicus 1 is illustrated up here on the top where you see scattered punctate foci of T2 hyperintensity. Physicus 2 shows just the beginning of confluent areas of white matter disease. And Physicus 3 shows larger confluent areas of white matter disease. You should note the atrophy pattern, particularly unusual patterns such as cerebellar atrophy, brainstem atrophy, cortical patterns of atrophy, hippocampal atrophy, or frontal temporal patterns of atrophy. A visual rating scale to assess the medial temporal lobe atrophy can vary, and it's age striated, so you need to be aware of those changes and how that can change in normal aging. Another useful scale of visual interpretation of atrophy and memory loss is the Kedem score, which looks at parietal atrophy. And then there are also global cortical atrophy scoring systems. This is the medial temporal atrophy score. If you look grade 0, here's the hippocampus. The temporal horn is barely perceptible. As you go from 0 to 4, you see that there's progressive loss of hippocampal volume and progressive enlargement of the adjacent temporal horn. Till grade 4, small hippocampi, large temporal horns. Global cortical atrophy scores are looking at relative sulcal widening. Here you can see that the gray matter opposes each other within the sulcus, so very little sulcal enlargement. Progressive enlargement of the sulci as you go from grade 1 to grade 2 to grade 3, where there's larger sulci seen here. Assessing the hippocampus is always done in assessment of looking for neurodegenerative disease. But I want you to note that that is not the end-all be-all. If you're looking at patients that are normal versus patients with Alzheimer's, there's a lot of overlap between hippocampal sizes. And there's almost no correlation of looking at the hippocampus to help you distinguish frontal temporal dementia from Alzheimer's disease. You see a very large degree of overlap. So instead, what you does better are visual scoring systems such as the medial temporal atrophy score, which I showed you earlier, not just looking at hippocampal volume. The hippocampal atrophy score actually combines information from both the temporal horn size and the size of the hippocampus. And if both are abnormal, you see that correlates better with MMSE than either hippocampal volume alone or the temporal horn volume alone. And obviously you have neither of those being abnormal, that correlates with a better MMSE. So there is information in the hippocampal atrophy score from the temporal horn size and the hippocampal volume, making it a better correlate with cognitive function. This hippocampal atrophy score performs slightly better in detecting mild Alzheimer's disease than either the hippocampal or the inferior lateral ventricular volume alone. Cortical atrophy scores are also useful, and they kind of quantifies the opening of the sulci, such as the visual GCA score, and the parietal lobe that correlates with the Kedem score. These scores perform better in detecting mild Alzheimer's disease than strict statistical measures of cerebral gray and white matter or the cerebral cortical volume. The anterior posterior score looks at this area of the frontal and temporal lobes and compares it to these posterior regions. And this is a useful ratio for helping distinguish frontal temporal dementia from other neurodegenerative causes. If we're looking at multiple different ways of distinguishing between controls and Alzheimer's disease and frontal temporal dementia and vascular dementia and dementia with Lewy body disease, you can see that all these MR parameters all have relative different sensitivities. The hippocampus and the medial temporal atrophy score are useful for distinguishing controls from Alzheimer's disease. The anterior versus posterior index score is good for distinguishing Alzheimer's disease from frontal temporal dementia. Looking at the white matter hyperintensity burden is good for distinguishing controls versus vascular dementia. But there's not always something good for distinguishing among these different neurodegenerative diseases. For example, if you're looking for Alzheimer's disease versus dementia with Lewy body disease, there's no great single measure for distinguishing dementia with Lewy body disease from Alzheimer's disease using these morphometric techniques. Let's look how we can apply these techniques in clinical practice. This is a 68-year-old male with memory loss, diabetes, and hypertension. Montreal Cognitive Assessment was 23 out of 30. You can see the overall volume change in this patient. We used high resolution T1 weighted imaging. We calculate the cerebral gray white matter. We calculate the cerebral cortical volume. We look at the hippocampal volume right and left individually, and you can see that both of those are low. We look at the inferior lateral ventricular volume, the lateral ventricular volume, and then individually looking at the hippocampal atrophy scores. You can see 1.8, 4.6, 95th, and 99th percentiles. So you can see that this patient has, compared to the normal database, is significantly below for this patient's age than expected in these volumes. If we want to, this computer algorithm can take that information and generate a predictive value, in this case assessing 75% probability of Alzheimer's disease in this patient and only a 25% probability of being clinically normal. Note that there are relatively large tails in both these curves and overlap, so that it's hard to achieve high values and sensitivity and differentiation, but I think this offers at least a statistical assessment rather than a subjective assessment of probability of Alzheimer's based on that patient's volumetrics. In addition, it can also help you consider whether adding cerebral spinal fluid or a PET scan might be helpful in helping further differentiate that, and in this case it can then assess whether, if that patient had a positive CSF test for Alzheimer's, what the predictive value would be for that patient being clinically normal versus Alzheimer's disease, or if they had a positive negative CSF, or if they had positive cerebral spinal fluid for Alzheimer's disease, you could increase your probability of Alzheimer's disease to 88%. So this gives you what the potential value of doing the next test is, whether it's cerebral spinal fluid or PET imaging. In addition, it can perform a differential trend analysis and among these four categories assess what the relative probability is for disease. So in this patient, 20% probability that the patient's cognitively normal and approximately 75% probability that the patient has Alzheimer's disease. And that's predominantly based in this patient on the hippocampal atrophy scores, relative cortical atrophy scores, and absence of white matter disease. This is a 63-year-old female with worsening memory. You can see that this program also can identify the white matter hyperintensities, and then it will calculate a lesion count and volume. It will calculate again the cortical and gray white matter volume, and then plot that for you against the normal distribution by age, the hippocampal volume, and plot that against the normal distribution by age. And then we can also calculate these other scores. So for example, the hippocampal atrophy score, the hippocampal volumes you see here, and you can see that the hippocampal atrophy score is more significantly abnormal than the hippocampal volumes in this patient. But the most important thing to look at in this patient is the anterior posterior score. And you can see that this is where this patient is. You can see that this is significantly deviant from cognitively normal patients, Alzheimer's patients, or patients with vascular dementia. So this is what's driving this clinical predictor that this patient most likely has frontal temporal dementia. This is a 72-year-old female with memory loss, few white matter foci, relative low burden of disease compared to age-matched controls. You can see where they score on their total cortical volume as well as their hippocampal volume, cortical gray and white matter volume. We can see here's their hippocampal volume, here's their hippocampal atrophy score, their global cortical atrophy score. This patient most likely has Alzheimer's disease, predominantly based on the hippocampal atrophy score being abnormal, no white matter disease burden, and you can assess as a relative probability based on these brain morphometrics among these four etiologies. Note that this clinical AI differential trend calculator only can use these four categories. It does not have additional categories, and it cannot say that there are mixed categories. It is forced into choosing probability of Alzheimer's disease, cognitively normal, FTD, or vascular dementia. It cannot take into account dementia with Lewy body disease, for example, because it doesn't really have any good parameters to differentiate that. And it can't say, oh, I think this patient has Alzheimer's disease and vascular dementia. But you visually can say if these, for example, are co-weighted, perhaps that might be an alternative explanation. Let's look at brain MR quantification in MS. We know that the McDonald criteria requires counting lesions in space and time, that this is useful both in diagnosis and follow-up. And this program also assesses the patient's brain atrophy, and that's a clinically relevant component of disease progression, particularly secondary progression in later stages of disease. MR quantification can help in detecting new lesions. It offers an objective, reproducible assessment of the number and volume of lesions in different territories. And it gives you an objective assessment of the atrophy with the ability to longitudinally quantify change. And doing this efficiently using computer-aided productivity can help radiologists generate the reports faster and hopefully more accurately. Again, you want to use volumetric protocols, both on MP range for T1 weighted information and on FLAIR for T2 weighted information. And in general, I find that we don't really suffer a significant time penalty using 3D FLAIR techniques for MS, so we sort of switched to 3D FLAIR for everything, because doing two axial and sagittal images, 2D techniques, take longer than just doing a single 3D FLAIR. Here is lesion detection. So these are 2D techniques, and you can see lesions here and here. And this is using 3D techniques, and you can see the same lesions here adjacent to the temporal horn and adjacent to the left frontal horn. However, you can also see these very small lesions, and in part using high resolution thin section 3D volumetric imaging can help you see small lesions. Let's see how that performs in some clinical examples. This is a 53-year-old female with multiple sclerosis, and we're doing a follow-up exam. And here, the computer is actually looking at 2 times in space and calculating that all these lesions in general are relatively stable. And it shows that those lesions were both on the first and second scan, and it displays those images in yellow. So this is a patient with predominantly stable, though relatively extensive white matter disease. This is a 42-year-old female with multiple sclerosis. This is their scan in 2017. This is their scan in 2015. You can note that there is a lesion adjacent to the right temporal horn. It was there before. There's a new lesion, however, here near the left temporal deep white matter, and another lesion here in the left occipital deep white matter, which are scored in red, indicating that these are new lesions. So here we see lesions that are stable are in yellow, lesions that are red are new, and it tells us how many new lesions there are. For example, there are 11 new lesions that it found in this on FLAIR. It found 7 new lesions on T1 weighted imaging, which are hypointense, and it also gives us what the changes are in this patient's brain volume over time. This is a 52-year-old female with multiple sclerosis. Scan 5, 2016, scan 6, 2014, stable lesion, new lesion scored in red, new lesion scored in red. So again, looking, we see lesions that are growing new lesions are scored in red, growing lesions are scored in orange, stable lesions are scored in yellow, and shrinking lesions are scored in blue. So you can see this patient has 9 new lesions with a total increase in volume of 0.7 milliliters. There are 2 new T1 hypointense lesions compared to the previous exam. You can see that there is relative progressive thalamic atrophy, which is not an uncommon finding in MS over time. And you can see that there's a change in 1.1% in volume of the thalamus here in over time. So we can both score new lesions, volume of lesions, and changes in atrophy over time. If you're interested in ordering a quantitative exam either for MS or neurodegenerative disease, there is a CPT code for that. It is 76377, which is 3D rendering with interpretation and reporting of computed tomography, MRI, ultrasound, or other tomographic modality. And we have this on our order forms. You can check this on our order forms, and then we would perform this type of volumetric scan, which is in addition to your basic exam interpretation and acquisition. Thank you, and feel free to contact us at Chesapeake Medical Imaging if you have any other questions. I would like to state that MR quantification is accurate and reliable. Using disease state comparisons, one can offer an appropriate differential diagnosis in dementia, though limited to 4 categories, and that the longitudinal assessment of MS disease and its burden assists reader identification of progression and allows objective lesion burden assessment and change.